everyone, we're going to start with the vascular disorders of the retina. In the vascular disorders of the retina, we have various vascular disorders of the retina, like we have diabetic retinopathy, we have the retinal artery occlusions, we have the retinal vein occlusions, we have hypertensive retinopathy, we have diabetic retinopathy, retinopathy of prematurity, sickle cell retinopathy. So there are a lot of vascular disorders of the retina we have. But in this, we are going to start with a very important vascular disorder of the retina, which is known as the hypertensive retinopathy. So what is this hypertensive retinopathy? These are the fundic changes which are occurring in the patient suffering from the systemic hypertension. So any patient who is suffering from the systemic hypertension, so this condition is occurring in those patients which are suffering from the systemic hypertension. Basically, pathogenesis says that there are basically various factors which plays roles in the pathogenesis of the hypertensive retinopathy, but these are, we have vasoconstriction, we have arteriosclerosis, we have the increased vascular permeability. So let's start with this. The first important factor is known as a vasoconstriction. What is vasoconstriction? It says that primary response of the retinal arterioles to the raised blood pressure is the narrowing and is related to the severity of the hypertension. It occurs in pure form in the young individuals but is affected by the pre-existing involutional sclerosis in the older patient. So pathogenesis में याद रखना, we know that hypertension में the first response in the patient, usually in the patient suffering from the acute hypertension, is basically the vasoconstriction. तो सबसे पहला response जो patient के अंदर आने वाला है, that is basically called as a vasoconstriction, basically in the patients or in the individuals who are suffering from the acute type of the hypertension. Now the second important step is the arteriosclerotic changes. Arteriosclerotic changes which manifest as changes in the arteriolar reflex. We'll see that normally we have a light and a bright reflex. There are changes which occurs in the arteriolar reflex, and there is AV nipping, which is a very important hallmark of the hypertensive retinopathy, resulting from the thickness of the vessel wall and are a reflection of the duration of the hypertension. That's why arteriosclerotic changes and which manifest as the changes in the arteriolar reflex are the signs of the chronic type of the hypertension. So in the patients in the chronic type of the hypertension, we have usually the arteriosclerotic changes and we have the AV nipping, and which is a very important thing that we have to remember. And in the older patient, arteriosclerotic changes may pre-exist due to the involutional sclerosis. Now the third important is increased vascular permeability. Next important step is the increased vascular permeability, which is resulting from the hypoxia and is responsible. Now what happens due to hypoxia? Next, whenever there is a hypoxia, it causes the breakdown of the inner blood retinal barrier and occurs in usually the SWARE type of the hypertension, which is going to occur in the SWARE type of the hypertension and is responsible for hemorrhages. We have the exudates, we have the focal retinal edema, we have macular edema, we have the macular edema, and we have the focal intraretinal periarterial transudates, and we have the disc edema. Next, we have the raised ICP, that is the intracranial pressure. Raised intracranial pressure occurs in the malignant or the accelerated hypertension and manifests as hypertensive optic neuropathy, characterized by papilledema and optic nerve ischemia. Next, these are the various grading of the hypertensive retinopathy. So first you have to understand about four important things. कि सबसे पहले अगर hypertensive retinopathy होने वाला है, the first thing is the vasoconstriction, the second is the arteriosclerotic changes which manifest as AV nipping and which manifest as changes in the arteriolar reflex. The third is increased vascular permeability, which causes the hemorrhages, exudates, focal retinal edema, transudates, and all that stuff. And we have the raised ICP, which is characterized by the papilledema and optic nerve ischemia. Now what are the various fundic changes which occurs in this patient? The various fundic changes are the generalized arteriolar narrowing. The first thing is considered to be the generalized arteriolar narrowing. Basically it has two phases. We have the vasoconstrictive phase and we have the sclerotic phases. In the vasoconstrictive phase, it's the diffuse vasospasm which is occurring, and the sclerotic phase which in which there is intimal thickening and the hypoplasia of the tunica media and the hyaline degradation, and is characterized by the arteriolar narrowing associated with the tortuosity. Now let's understand, next thing is known as the focal arteriolar narrowing. The next is the focal arteriolar narrowing seen as the area of the localized vasoconstriction. Next is the AV nipping, which is defined as the hallmark of the hypertensive retinopathy, which refers to as which occurs when the arteriole crosses and compresses the vein. So when the arteriole crosses and compresses the vein, as the vessels share a common adventitious sheath, and this is known as the AV crossing changes. It includes Salu signs, Bonnet signs, and the gun signs. These are very important signs which occurs in the hypertensive retinopathy. Salu signs means the deflection of the veins at AV crossing. Bonnet sign is a banking, before bonnet, before banking of the veins distal to the AV crossing. We have the gun sign, which is a tapering of veins on the either side of the crossing. So these are the various signs which occurs. Then we have the arteriolar reflex changes. Now the first, we have to understand what is a normal arteriolar reflex, which is a bright, thin, linear reflex. So this is a reflex which is a normal light reflex of the normal retinal vasculature, which is formed by the reflection from the interface between the blood column and the vessel wall. So normal is this, but when it's a grade 1 and grade 2 of the hypertension, which we'll see, it's a diffuse and a less bright reflex. We have the copper wiring. What is copper wiring? It's a reddish brown reflex of the arterioles, occurs due to the progressive sclerosis and the hyalinization, and it is a sign of the grade 3 type of the hypertensive retinopathy. We have the silver wiring. Silver wiring means there is an opaque white reflex of the arterioles occurring ultimately due to the continued sclerosis and is seen in the grade 4 type of the hypertensive retinopathy. Then there are the superficial retinal hemorrhages, which are usually the flame-shaped type of the retinal hemorrhages, which are usually seen in the posterior pole. We have the hard exudates. What are the hard exudates? These hard exudates are basically the lipid deposits in the outer plexiform layer of the retina, which occurs following the leaky capillaries. These occurs due to the leaky capillaries. We have the leaky capillaries. Due to the leaky capillaries, there are some leaky capillaries in the severe type of the hypertensive retinopathy, and these appears as the yellow waxy spots. These are going to appear as the yellow waxy spots, and these have sharp margins. These are seen in the posterior pole and may be arranged as macular fan and the macular star. Very important sign, macular fan or the macular star, as macular fan or the macular star. And we have the cotton wool spots. Cotton wool spots are the fluffy whitish lesions and represents the areas of the infarcts in the nerve fiber layer. These occurs due to ischemia caused by the capillary obliterations in the sphere form of the hypertensive retinopathy. Now these are also termed as the soft exudates. These are also known as the soft exudates. We call them to be as the soft exudates. Right, so we have the hard exudates, we have the flame-shaped hemorrhages, next we have the macula, changes in the macula, we have the cotton wool spots, and it's a picture of the retina. Let's start with the grading. Now, what is a grading of the hypertensive retinopathy? So, in the grading of the hypertensive retinopathy, always remember we have the Keith and the Wagner classification, we have the modified Ski classification, and we have the Mitchell-Wong classification. In this, let's start with the Keith and the Wagner classification. Has classified the hypertensive retinopathy into 4 grades. We have the grade 1, which consists of the mild generalized arteriolar attenuation, particularly of the small branches, with the broadening of the arteriolar light reflex and vein concealment. Grade 2 comprises marked generalized narrowing and the focal attenuation of the arterioles associated with the deflection at AV crossing, which is the Salu sign. It's important, like in the grade 2, we have the Salu signs and the focal attenuation and the generalized narrowing of the arterioles. Then the grade 3 is characterized by the grade 2 signs and plus the copper wiring of the arterioles. We have the banking of the veins distal to the AV crossings, which is the Bonnet sign. We have the tapering of the veins on either side of the crossing, which is Gun sign, and the right angle deflection of the vein, Salu sign. Flame-shaped hemorrhages, cotton wool spots, and the hard exudates are also present. In the grade 4, always remember we have all the changes of the grade 3 plus there is silver wiring of the arterioles and papal edema. Now, clinical types, or the hypertensive retinopathy is basically can be of 4 circumstances. We have the hypertension with the involutional or the senile sclerosis, with the hypertension occurring in the elderly patients after the age of 50 years. In the presence of the involutional sclerosis, the fundic changes comprises augmented atherosclerotic retinopathy. We have the hypertension without the sclerosis, which is going to occur in the young people where the elastic retinal arterioles are exposed to the raised blood pressure for the shorter duration. There are few retinal signs. These arterioles are constricted, pale and straight with the acute angle branching. Next, we have the hypertension with the compensatory arteriolosclerosis, which is seen in the young patients with the prolonged benign hypertension, usually associated with the benign nephrosclerosis. Then we have something called as a malignant hypertension. Whenever we are going to understand about the malignant hypertension, we have to understand it's not a separate variety of hypertension, but it's an expression of its rapid progression to a serious degree in a patient with the relatively young arterioles undefended by the fibrosis. The fundic picture is characterized by marked arteriolar narrowing. We have the papilledema, and an essential feature of the malignant hypertension, retinal edema over the posterior pole, clusters of superficial flame-shaped hemorrhages, and an abundance of the cotton wool spots. Whenever we are going to discuss about the malignant type of the hypertensive retinopathy, we have to understand that the fundic picture of the malignant type of the hypertensive retinopathy includes the changes of acute hypertensive retinopathy, we have the acute hypertensive choroidopathy, and we have the acute hypertensive optic neuropathy. So what is the acute hypertensive retinopathy is going to include these changes, which includes marked arteriolar narrowing, superficial retinal hemorrhages, FIPS, we have the cotton wool spots, microaneurysm, shunt vessels, and collaterals. But what is going to happen in the choroidopathy? There are some important features of the choroidopathy, which includes Elschnig spots, which are the focal areas of the infarcted retinal pigment epithelium. We have the Segrist streaks due to the fibrinoid necrosis in the malignant hypertension. Now, these are the malignant hypertension. There will be the retinopathy, which we have discussed. There is the choroidopathy. Now, choroidopathy also includes serous type. We have the serous type of the neurosensory retinal detachment. Retinal detachment. We can have some acute focal retinal pigment epitheliopathy. Next, we have something called as the malignant also associated with the renal insufficiency. So this is about some of the important part. Now there is something about the choroidopathy. After that, there is acute hypertensive. In the malignant hypertension, there is something optic neuropathy also, which includes disc edema. We have disc edema in that. We have disc edema. We have disc pallor. We have the disc pallor in that. We have disc edema. We have the disc pallor and hemorrhages on the disc and the peripapillar retina. So this is something about the hypertensive retinopathy, and which includes the hypertensive retinopathy, and we have the malignant type of the hypertensive retinopathy, which includes as acute hypertensive retinopathy, acute hypertensive choroidopathy, and acute hypertensive optic neuropathy. Now it says that what is a management? The management is simple. Like if it's a mild hypertensive retinopathy, BP control has to be there, and in the moderate type, we have to go with the BP control and assess the cholesterol levels. If indicated, cholesterol lowering agents has to be given. Next, accelerated hypertensive retinopathy, malignant type, urgent antihypertensive measurement by stepwise control of the BP over the few hours is necessary. So this was about the hypertensive retinopathy. Next, there is a topic which is known as the retinopathy in the pregnancy induced hypertension. That is known as the retinopathy or the retinopathy in the pregnancy induced hypertension. So what is this? Let's discuss. Pregnancy-induced hypertension, previously known as the toxemia of the pregnancy, is a disease of an unknown etiology. We don't know the etiology, which is characterized by the raised blood pressure, proteinuria, and the generalized edema. Now, the retinal changes are liable to occur in this condition when the blood pressure rises above 160 to 100 mm of Hg, and are marked when the blood pressure rises above 200 to 130 millimeters of Hg. Earliest changes consist of the narrowing of the nasal arterioles followed by the generalized arteriolar narrowing. Sweat-resistant spasm of the vessel causes the retinal hypoxia characterized by the cotton wool spots, which are the infarcts of the retinal nerve fiber layer, and the superficial hemorrhages. If the pregnancy is allowed to continue, further progression of the retinopathy occurs rapidly. Retinal edema and exudation is usually marked and may be associated with the macular star or flat macular detachment. Rarely it may be complicated by the bilateral exudative retinal detachment. Prognosis for the retinal detachment is good as it occurs spontaneously within the few days of the termination of the pregnancy. What is the management? Changes of the retinopathy are reversible and disappears after the delivery unless organic vascular disease is established. Therefore, in pre-organic stage, whenever there is anything, like in case of the pre-organic stage, when the patient responds well to the conservative treatment, the pregnancy may be justifiably be continued under close observation. However, the evidence of the hypoxic retinopathy, like if there are signs like soft exudates, which are cotton wool spots, retinal edema, hemorrhages, should be considered an indication for the termination of pregnancy. Otherwise, permanent visual loss or even the loss of life of both the mother and the fetus may occur. So this was about the management. Changes are reversible, disappear after delivery. In pre-organic stage, conservative treatment, pregnancy is continued under the close observation, but we have to look for some of the important evidence of the hypoxic retinopathy, like cotton wool spots, hemorrhages, retinal edema, indication for termination of pregnancy. Otherwise, permanent visual loss or even the loss of life may occur. So this was about our hypertensive retinopathy. So okay, bye bye.